Welcome back. This is Dr. Teresa Toscano, your resident speech therapist specializing in infant feeding and lactation. But more importantly, I'm a future mom-to-be on a mission to provide free feeding therapy to other moms because, as I always say, good speech starts with good eating. So today I will be talking about reflux in infants and children. Now, I want to talk about this because a lot of times as a feeding specialist, I will see children that have this. So what is reflux? It's a condition where the stomach contents flow back up into the esophagus, which is that tube that connects our mouth to our stomachs. Now, many babies experience reflux, and it's important to note that reflux can be observed or noticeable or silent. And silent reflux is when reflux is occurring, but there's no exhibiting signs or symptoms such as like spitting up or wet-sounding burps. So just keep that in mind, parents. One reason a baby experiences reflux is due to weakness in the muscles that keep the food from coming back up. And this muscle is the lower esophageal sphincter. And now this weakness can be inherited, or it's just the muscle is not strong enough yet. That's why daily tummy time is really important because it helps strengthen that abdomen, that abdominal area, and then just all those supporting muscles. Reflux can also result from overeating, even if it's just by the slightest bit of extra food. And a good rule of thumb for really everybody is that your stomach is the size of your fist. So when we think of a baby's fist and it's so very small, then their stomach is so very small. And if a baby is overfed, even by half an ounce, this can be too much for them. And this is why it's recommended to feed babies small portions more frequently throughout the day, especially if the baby is experiencing reflux or to prevent any potential reflux. Another potential cause of reflux is oral ties. Now, this topic seems to cause the most controversy when, in my opinion, it really shouldn't be. It's very medical to me, but we're still going to have fun talking about it and just go over why it causes discussion. First, what are oral ties? They are tongue ties, lip ties, or cheek ties. And a tie occurs when there's skin that attaches those oral structures I just mentioned to its surrounding anatomy, but preventing full range of motion. That's really the key. That's what makes it a tie. Because we have frenums that attach our tongue to the bottom of our mouth, our lips and our cheeks to the top of our gums, and that is naturally occurring. But again, key point is when those frenums become too tight. That's what becomes a tie. And in my opinion, restrictive oral ties are detrimental because if there's too much restriction, the lips, the tongue, the cheeks cannot create a proper seal, especially for infants when we're feeding. And again, not only does that create feeding difficulty, which is, a topic I discussed earlier in a different video, but also when you can't create a good seal, your baby ends up consuming air when they're feeding. Now, consuming air, as we all know, is very uncomfortable for, again, everyone because it creates bloating, gas, burping, abdominal pain, that feeling of getting full very quickly, and belching. So when it comes to infants, we see a fussy, cries a lot during feeds baby, and this often leads to a failure to thrive diagnosis because those babies don't want to eat. They don't understand the cause and the effect, and they can't rationalize that it is just a momentary feeling. And so they just learn that when I do this, when I eat, I get pain, so therefore I'm not going to do it. This topic becomes controversial because we have healthcare providers such as pediatricians or even gastroenterologists, GI doctors that don't recognize the importance of correcting a restrictive tie. They don't see it as a problem. They say they'll grow out of it. That plus one solution to this problem is to do a tie release, which is with an oral surgeon involving cutting or lasering the frenum, essentially removing that attaching skin. Now, this is not the only solution to correcting oral ties. But in my experience, what I've seen, when a parent hears that option on top of what they're hearing from their healthcare providers, downplaying the importance of addressing restrictive ties, oh, they'll grow out of it, parents really get just turned off from the conversation of addressing those ties. Now, I do want to stay on the topic of reflux, so I will make another video addressing tongue ties and just as the speech therapist, my perspective on it and how to correct it and all those things. But I do just want to emphasize to parents, to wrap this section up, is that the sooner you address something, the more options you have, especially with tongue ties. I know in the future when my little baby comes that if I'm only told by a provider that there's only one option you have, I know that would make me feel a certain way. So I really do want to emphasize to parents that it may sound a bit overwhelming, the idea of, tongue ties or grow out of it. I just want to emphasize, go have a consultation, go talk to someone, see what they say, see if that relates more to you. The earlier you do it, the more options you have. So, okay, moving back to reflux. Addressing reflux is important because consistent and uncontrolled reflux can cause health concerns such as respiratory issues. It is known that reflux can travel into your child's middle ear via the eustachian tube or into their nasal and sinus area, causing ear and sinus infections. Additionally, if reflux ends up flowing into the airway, then your baby could eventually develop asthma. Reflux also causes health concerns because research has shown that there's a potential connection between reflux and sudden infant death syndrome, or SIDS. As we all know, the new standard of practice is to have babies sleeping on their backs because it is reported to reduce the number of deaths from SIDS significantly. And now this relates to reflux, as some healthcare providers believe that reflux may be a major contributor to SIDS, and sleeping on your back prevents the chance of reflux spilling over into the airway. Let me explain. If your baby is sleeping on their stomach and reflux occurs, there's a greater chance that the contents that are coming up from reflux will spill into the airway because gravity will pull the spit up back down towards the airway. So very quickly, here's the front of the baby where the lungs are, and here's the back of the baby, which is the tube that goes from the mouth to the stomach. So if the baby's sleeping on their stomach and contents come up, again, when it gets to that upper esophageal sphincter and enters into this whole pharynx and larynx area, gravity will pull the spit down, just to kind of explain that a little bit more. And so as adults, when something gets near or enters our airway, our reflex to cough kicks in to clear our airway. Babies are really just not as experienced with coughing. They can, but they're just not as strong as adults. So because of that, plus laying on their stomach when they're not that strong, plus gravity, a child is more likely to choke or suffocate due to the vocal fold closing as a response to protecting foreign objects going into the lungs. Also, when a baby sleeps on their back, they tend not to fall into as deep of a sleep as babies that sleep on their stomach. Now you may be thinking, wouldn't it be better that a baby has a deeper sleep? Yes, I think in theory we all want better, deeper sleep. However, if reflux does occur and baby is not in such a deep sleep, your baby is more likely to wake up because of the moro or the startle reflex. And therefore, if your baby ends up spitting up while sleeping, they're more likely to wake up, which increases their protection of the airway. Now, here's the tricky part to all of this, but there are exceptions to every rule. There are some cases when a baby has a lot of reflux and the pediatrician may recommend that your baby sleeps on their belly with a SIDS monitor. This is because the occurrence of reflux seems to decrease while your child sleeps on their stomach. I know this seems contradictory to everything I was just saying, but hear me out, or at least hear the theory out. Placing babies in a prone position or on their bellies with a wedge or a raised mattress has been used in hospitals and by parents. This prone position allows the baby's digestive system to elongate. And this can place a smaller amount of pressure on the esophagus and that lower esophageal sphincter muscle, which helps keep the food in their stomach. However, the most important thing to remember is that any baby that sleeps on their stomach must wear a SIDS monitor. And again, I'm not a doctor, so follow your doctor's recommendations, but this is just the information out there. Another solution that you might hear recommended by a pediatrician is to have your baby sleep in a car seat, where they're essentially sleeping in an upright position is based on the theory of just having gravity keeping the food down. However, a lot of parents note that their babies just ends up being fussier in that position and causes actually more reflux, because a baby essentially in this upright position, the baby ends up scrunching more and their stomach gets squeezed a little bit more, and they end up not sleeping and it's uncomfortable. So I don't personally, as a non-medical doctor, recommend it, but it's just you may hear it. Now, if your baby just ends up having really uncontrollable reflux and you've tried different bottles, different formulas, smaller feeds, it just keeps happening. Again, we'll leave the tongue tie, situation. Your pediatrician will probably recommend other specialists, such as a GI doctor. The one thing I recommend is that if your doctor encourages a consultation to see a GI doctor, I would ask the pediatrician to also get referrals to other providers, such as a lactation specialist, occupational therapist, and a speech therapist, specializing all in feeding intervention. Now, why do I recommend this? It's because many times when you, as the parent, end up just seeing one doctor at a time, and this doesn't really just involve babies, it's actually for everybody. When you're recommended one doctor at a time, you are potentially delaying finding the solution for yourself, because everyone's individual. Not every problem is, this is the problem and here's the solution. Sometimes it takes different specialists, it takes different opinions, different methods, combining different things to find the perfect solution. And when it comes to infant feeding, I can't emphasize this enough, is that it is actually time sensitive. Now, I'm not trying to put pressure on you, but what happens, as I was kind of mentioning earlier, what happens is that babies can't rationalize what's happening to them. The more time that passes, they're not stupid. They just can't understand the whole picture. But they end up realizing that if I keep doing A, then B happens, and B is really uncomfortable and I don't like it. Therefore, I'm not going to do it. If you do one consultant at a time, you're just extending this time, and because every day your baby feeds multiple times a day, it's almost a trauma that is happening for the baby, right? Every time they eat, they get an upset stomach, they burp, it's uncomfortable, they're fussy, they cry, they don't want to eat anymore. So as the days keep going, more trauma keeps happening in the baby's mind. More trauma is happening. And in my experience, this is the typical course. They see the pediatrician tries, different bottle, different formula, XYZ. Then they go to a GI doctor. GI puts them on medications. That helps, or it doesn't help. If they have to get to me as the feeding therapist, it's usually 6 months. The parents are trying to get off of milk. They're trying to start purees. The babies don't even want to eat anything. And we have to spend so much time to reverse the issue. And as a speech therapist, I'm kind of a little bit of their last Hail Mary. But parents are so eager to fix the problem that they think it'd happen overnight, where really it's taken 6 months. Really, 6 months have passed and 6 months of trauma. You need at least that to try to fix it. I cannot encourage enough that if other consultants are being recommended by your pediatrician, see them all. I know that's a lot on you parents. I know that's a lot on your time, possibly your money in that little moment, but it's going to be even more time and more money and more stress when you do one by one when it comes to your baby's eating. And that's my recommendation as a mom-to-be, as a speech therapist, someone who's also studied lactation. The sooner, the better. As I mentioned before, the sooner, more options. So that is it for today. If you found any of this helpful, be sure to subscribe so you don't miss any of my future videos. I've got a ton of content that I want to talk about, and I'd love for you to be a part of it. But I do have a little update. I made a book. So it is called I Love My Fruits and Vegetables, A Fun Way to Embrace Healthy Eating. It is an interactive book. It's really for toddlers at 3 to 6 years old. It can be for older kids, of course, but it is a bit more illustrated for younger kids. And it is an interactive coloring, dot-to-dot, and motivational book for picky eaters. So I just kind of want to show you a little bit inside. You can find it on Amazon. If you write I love my fruits and vegetables, it should come up. It looks like this. And essentially it goes through the steps of what I would do in a much more simple way for older picky eaters. But so it has all different fruits and vegetables. It has the dot to dot. So you're promoting hand-eye coordination, you're promoting counting, just cognitive skills. Then you can color it in. It has a little description at the bottom to kind of make that food a little bit less intimidating. And then on the following page, it kind of goes through a step of I can touch my food, I can kiss my food, bite my food, eat my food. Then they get a star at the end. And I know I made it, and I'm trying not to say this in any biased way, but I do think it's a really cute book. So yeah, just wanted to say that I made a book. All right, Dr. T, signing off. See you soon.